Welcome to the series where I'll be discussing the 2026 Consensus Statement on the Algorithm for Management of Adults with Type 2 Diabetes by ACE. This is Endo in a Bite, where I break down endocrine concepts or lengthy guidelines into focused, high-yield pieces you can actually remember. For the full board-centric framework, I've built it all out in Easy Endo Prep, designed to keep you efficient, current, exam-ready, and sharp in clinic. Visit www.ezendoprep.com to enroll in the full course or start your free trial. This is the first of 3 episodes reviewing the 2026 ACE approach to insulin management in adults with type 2 diabetes. In this episode, we will focus on the goals of insulin therapy, the role of CGM, individualized glycemic targets, severe hyperglycemia, and how GLP-1-based therapy fits into the decision to start insulin. Insulin should be initiated when non-insulin therapies no longer achieve the patient's individualized glycemic target. For an appropriate adult, an A1C of 6.5% or lower may be reasonable when it can be achieved safely with minimal or no hypoglycemia. However, insulin should not be adjusted based on the A1C alone. The A1C reflects average glycemia, but it does not show the daily glucose pattern. It may not identify fasting hyperglycemia, post-meal hyperglycemia, or episodes of hypoglycemia. Insulin decisions should therefore be guided by fasting glucose, pre-meal glucose, 2-hour post-meal glucose, and CGM data whenever available. CGM provides a comprehensive assessment of glycemic control. Important metrics include time in range, time below range, time above range, glycemic variability, and the glucose management indicator. For many adults, the usual CGM target is to spend more than 70% of the time between 70 and 180 milligrams per deciliter. Time below range should be minimized, with less than 4% below 70 and less than 1% below 54. Time above range should generally remain below 25% above 180 and below 5% above 250 milligrams per deciliter. In my board review course, Easy Endo Prep, I have created a brief audio aid, a song, to help reinforce and memorize these specific percentage goals. The link to the YouTube video is included in the show notes for today's episode. This reflects the central purpose of Easy Endo Prep, to simplify complex endocrine concepts and make high-yield board review information easier to understand, retain, and recall. Now let's talk about glycemic variability, measured by the coefficient of variation, or CV. The general target is 36% or less. A CV above 36% indicates greater glucose variability and is associated with a higher risk of hypoglycemia. However, in patients treated with insulin, a tighter target of below 33% is often preferred, since lower variability is associated with a lower risk of hypoglycemia. The glucose management indicator provides an estimate of overall glycemic control based on the CGM data. CGM helps identify overnight hypoglycemia, fasting hyperglycemia, post-meal excursions, and excessive variability. It supports insulin optimization while reducing hypoglycemia risk. Evidence supports routine CGM use in adults receiving insulin therapy whenever it is feasible. Fasting and pre-meal glucose targets are often below 110 milligrams per deciliter when this can be achieved without hypoglycemia. But the target must account for age, frailty, comorbidities, chronic kidney disease, cardiovascular disease, and the patient's overall clinical status. The goal is not simply to normalize a number. The goal is to improve glycemic control while minimizing hypoglycemia and treatment burden. Lifestyle intervention and other diabetes therapies that benefit complications and comorbidities should be continued when appropriate. Now let's discuss when insulin should be started promptly. Clinical features suggesting marked insulin deficiency include symptomatic hyperglycemia, polyuria, polydipsia, weight loss, dehydration, fatigue, and a catabolic state. Biochemical thresholds that favor basal insulin, with or without prandial insulin include an A1C greater than 10% or a blood glucose greater than 300 milligrams per deciliter. These thresholds are especially important when they are accompanied by symptoms or catabolic features. In that setting, initiate basal insulin with or without prandial insulin and reduce glucose as promptly and safely as possible. Do not delay insulin while waiting for another medication to work. Also consider whether the patient may have type 1 diabetes or another cause of diabetes. Testing should be considered when the clinical presentation is not typical for type 2 diabetes. In severe hyperglycemia requiring rapid correction, a GLP-1 receptor agonist or a dual GIP and GLP-1 medication should not be used alone. Combination with basal insulin may be considered depending on the clinical situation, but insulin remains the priority when rapid correction is needed. Outside of severe or symptomatic hyperglycemia, the sequence is different. If the patient is not already receiving one, consider a GLP-1 receptor agonist or a dual GIP and GLP-1 medication before initiating insulin. Basal insulin should be initiated when GLP-1 base therapy is insufficient, contraindicated, not tolerated, inaccessible, or otherwise inappropriate. When insulin is started, beneficial non-insulin therapies should generally be continued when appropriate. This includes GLP-1 based therapy when it remains clinically useful. Basal insulin may be initiated alone. In selected patients, it may also be initiated as a fixed ratio combination with a GLP-1 receptor agonist. The central distinction is the clinical presentation. In severe symptomatic hyperglycemia, particularly with catabolic features, initiate insulin promptly. In a clinically stable patient without severe hyperglycemia, consider GLP-1 based therapy before insulin when appropriate. Here are the take-home points. Use individualized glycemic targets. Do not adjust insulin based on the A1C alone. Use fasting, pre-meal, post-meal, and CGM patterns. Consider prompt insulin when the A1C is greater than 10%, glucose is greater than 300, or symptoms and catabolic features suggest marked insulin deficiency. And remember that GLP-1 based therapy may come before insulin in a stable patient, but it should not delay insulin when rapid glucose correction is required. This was another bite-sized episode of Endo in a Bite. If a detail went by too quickly, don't worry. I've prepared the notes for you. Visit www.easyendoprep.com to sign up for the weekly newsletter and have all the key pearls delivered straight to your inbox. You can also purchase the full board review course there for deeper learning and ABIM exam preparation. Remember, stay consistent, and together we'll work through the ACE consensus statement on the algorithm for the management of dyslipidemia, one bite at a time.